Hi, Instructor Williams. My name is Kristen Eady, and this is my informative speech on end-stage renal disease with an emphasis on dialysis. These are my audience members.
I'm Jeannie Germain, her mom.
And I'm Andy Morgan, her fiance.
Okay.
We'll go over here.
Okay, today I'm going to talk about end-stage renal disease and the treatments that these patients have to undergo. As we go about our daily lives, we fail to realize the important role that our kidneys play and the things that they do for our bodies. There are approximately 26 million people in the United States that are living with end-stage renal disease. These patients rely on dialysis to sustain their daily lives. While researching this speech and also working as an LPN for one of the top dialysis centers in the country, I get to spend countless hours with these patients and their families. Today, I invite you to learn about end-stage renal disease, the types of lifelines or accesses that are placed in these patients, and the process of dialysis. So let's get started. End-stage renal disease is when the kidneys actually stop functioning completely. You're not able to sustain any kind of quality of life. There are many factors that can cause this disease process. The number one being diabetes that is uncontrolled. The second one being high blood pressure, which is also uncontrolled. And the third is being on prolonged medications that can damage your kidneys. There's lab tests that can be done that can diagnose this disease process. The first thing is to have your blood pressure checked regularly to make sure that it is within normal limits. Urine testing, such as a 24-hour urine collection, which calculates your input and output, and then also blood testing for an eGFR, which is the actually values of what your kidney functions for your body. After you received your confirmed diagnosis, surgical arrangements are made for your access to be placed. Accesses are the lifeline for these patients. There's three types. One is not permanent. That's our central venous catheter, also known as the CVC. The catheter is placed in the superior vena cava. The tip of the catheter is placed at the junction of the superior vena cava and the right atrium of the heart. Alternate sites can also be used: the external jugular vein, the subclavian vein, or the femoral vein, which is located in your thigh. Double lumens are attached to the end of the catheter and allow for an exterior access so that the CVC can be used to perform treatments. CVCs can be placed immediately and used immediately, but they're also removed as soon as possible because they're very susceptible to infection. Our second type of access is a fistula, and this is the result of a surgical procedure that links an artery and a vein. The most common involves the radial artery and the cephalic vein, which is located in your wrist. A well-working access will contain a positive bruit, which is a swishing sound that it makes, and a positive thrill, which is the pulse that you feel. A fistula takes anywhere from 3 to 6 months to heal, and it takes that long for it to mature so that the needles can be placed. A graft is our third and final access. It's an artificial tubing that's made from a bovine material. Bovine material would be like pig or cow, something synthetic. And it's surgically implanted under the skin to connect the artery and the vein to promote an easy cannulation. The most common construction for a graft is what we call a loop graft, and it connects the brachial artery and the cephalic vein and the antecubital fossa. Grafts have to be replaced more often due to wear and tear of the tubing in the arm, so they're not as popular as a fistula. Now that we have our accesses placed, I'm going to explain a day in my life as an LPN at DaVita Dialysis. My patients come in to me 3 days a week. They stay anywhere from 3 to 4 hours, depending on a doctor's order. The doctor's order also contains a blood flow rate, a needle gauge size, and a dry weight. Their dry weight is what we try to get them to each treatment when we remove fluid. Patient walks in, first thing they do is weigh, and then we also ask them to wash their hands and their access. This is a preventative measure for any type of infection. A standing blood pressure is always taken along with a sitting. A nurse's assessment is done, which includes listening to the heart, listening to the lungs, listening to the access for that positive bruit and thrill, and then also checking the extremities for any kind of outstanding edema, which is fluid. After this is done, the access is inspected again, and then we begin a cleaning process with alcohol and betadine. This is allowed to dry. 2 needles are then placed into the access. One is a venous line, which takes the blood to the body, and the other is an arterial line, which takes the blood away from the body. The patient is hooked up to a machine for their prescribed time, anywhere from 3 to 4 hours, and the removal of fluid starts. Fluid is also removed along with waste, and this is done with a filter, which is what we call a dialyzer, and it takes 2 ounces of blood out of the body at a time. Vital signs are monitored every 30 minutes through the treatment to ensure that there's no complications such as cramping or nausea or vomiting, which is something that these patients can go through with the removal of fluid. After treatment's completed, the patient's blood is returned with 400 milliliters of normal saline. The needles are removed, and the patient is encouraged to hold their sites with their hands and apply pressure. This makes the bleeding stop anywhere from 5 to 10 minutes. The patient weighs, and all the information from the treatment is then documented into the patient's chart. So as you can see, dialysis is a very, very, very important process for these patients. It allows them to sustain their daily lives and their daily routines. And I can honestly say with working with all of them, they're pretty brave and truly amazing people. Thank you. Hey, audience members.
What do we do now?
You have to say that you're still here.
I'm Jeannie and I'm still here.
I'm still here at the residence right now.
Thank you.
Thank you.
I was going to say me and Jeannie.
Well, I'm sure.
Zena, we didn't get